and yet you can't even reproduce it. But you can close your eyes and think of your first love and get that warm, good feeling. Pain, you can't do it. It's so complex, and that's what I'm going to try to explain to you, how it's so complex, how we try to understand it, what some of the basic biology is, and more importantly, how do we treat it, because there's lots of ways to do it. Now, pain's not all bad, all right? Here is a boy who has what's called congenital insensitivity to pain. This is somebody who has a mutation in a gene and never feels pain, never experiences pain. Now, as many of you know, acute pain is a signal, it's a warning signal. It says something is wrong, you may have broken a limb, you might bite your lips or whatever happened, and you stop and you learn. So acute pain is important, and to have a drug that would eliminate all acute and chronic pain would be bad, all right? Just for the record, there's a new gene that was identified, literally just came out 3 months ago, a Pakistani family, and it turned out the way they found them, these kids were firewalkers, and they just never responded. And they identified the gene, and the drug companies are hot on that gene because the hope is you can develop a drug to target it and control it. We'll see. But chronic pain is the problem. Acute pain is important. Some of the features that I'm going to talk about. First thing, pain is not a stimulus. Everyone says, that was a painful stimulus. Well, I use that term, and people use it. There's no such thing as painful stimuli. As you'll see, pain's in the brain. It's a perception. And what's special about pain, it's not just something that's an intense stimulus that might produce tissue injury. Pain has what we call sensory discriminative features. It localizes to a certain part of the body. It has certain intensity, of course. It might be thermal, it might be mechanical, it might be produced by a chemical. That's just one aspect of what produces pain. That's the stimulus. What's key in my mind is that it has an affective or emotional component to the experience. In other words, it motivates you. All right? If there is no emotional component to the experience, in my mind, it's not pain. It's just saying, yeah, that's intense. There actually are syndromes, people with brain lesions, who have what's called la belle indifférence, the beautiful indifference, where literally it's say, oh, yeah, that really hurts. Yeah, it's very intense. Sure, sure. And they go on reading. Just nothing. Just blank stare, nothing. In my mind, it's not pain. And then, of course, there's a cognitive component. And what I mean by that is the context in which you experience the injury or the stimulus will make a big difference. The football player who's playing and doesn't realize it because of the game. The woman who went through Lamaze. All right, I'm not suggesting that Lamaze eliminates pain. I wouldn't dare say that with an audience that's mostly made up of women. But it can reduce the pain. It can help. Same stimulus, two women with exactly the same stimulus, but two different pain experiences. All right? Somebody wants the baby, somebody doesn't want the baby. It will make a difference. So pain is much more than just the stimulus. And that's one of the reasons why it becomes very difficult to measure, because it's a subjective experience. You can't see it. If somebody is paralyzed, you can relate to that. You can pretend you're paralyzed. You can pretend you're blind. You can even pretend you have Parkinson's. You can have a tremor. You can walk slowly. But you can't, how do you pretend you have somebody's pain? You can't do it. You can't even reproduce your own pain. You can't see it. And so it becomes difficult to measure, but this is actually interesting and important. We use very simple tools, and this is now a requirement in the hospital, amazingly only recently. How many people remember when they were in the hospital and something started to hurt and you kept pressing the button until somebody would show up and they say, what's the matter? You say, well, the pain's back, and they might give you something and they go away, and then you keep pressing and they come back an hour later. Well, it doesn't work that way anymore. It's now a law that the individual, whether it's a nurse or a physician, on a regular basis must come in, take your blood pressure, respiration, and say, how much pain do you have? And they use what's called the visual analog scale, which goes from 0, no pain, to 100. And the important thing to understand about this, it actually works. It's very effective. But if you, sir, say my pain is 70, and you say 70, it doesn't mean you have the same pain. It's irrelevant. What it means is you started off, you came into the hospital with a 70, and we gave you some drugs, and now we ask you to, you say 40. Aha. You went from 70 to 10, probably gave you too much drugs, but it worked, all right? The difference, and it's very effective. If you have surgery and you have post-op pain and you're suddenly going from a 20 to a 70, I can actually scale it in the scaling. So it's very important. What do you do with kids? Well, then you use what's something called the Alcher scale. Children, you can look at their face and try to imagine how much pain they have, and it correlates, or their cries. Or you can ask the kids to point to the pictures. How much pain do you have?